So, welcome everyone to this webinar of the European Lupus Meeting 2024. During this webinar, we're going to give you some feedback about the European Lupus Meeting, and hopefully you will learn a lot more about what happened, the interesting presentations that went on from the people that Lupus Europe invited to come. So, beginning at the beginning, March 20 to 22nd, the European Lupus Meeting took place in Bruges in Belgium. Lupus Europe was there. We had 21 active volunteers participating. We have PAN members, youth group members, translators, and so on. And apart from sending them out and letting them follow different sessions, we asked them to perform interviews of the interesting speakers and also provide their own top takeaways. So before we play an hour-long video of all the feedback that we have, which is really amazing, we have a few people who are going to present live tonight with their feedback. So Sabine, would you mind going first?
No, absolutely not. Hi. Um, it was uh, an incredible experience, first of all, to meet all patients, and the other opportunity to see the speakers and hear the talks and, well, get a first-hand knowledge of what's new in lupus and, yeah, getting the chance to talk to the doctors. It was really, yeah, a new experience and it was really nice. Thank you.
Thank you so much, Sabine. It was a pleasure having you there. So, Elfriede, would you mind going next?
Yes, I will go next. Well, I totally agree with all that Sabine has said, of course. Um, for me, well, there were a few things that I took away from the meeting to home. And first of all, I found it very, very encouraging to sometimes you can feel a bit alone with your lupus and you can feel as if there's not anything changing when you're talking to your doctor. Well, no, there's nothing new. We're still trying to find out more cures. And at the ELM, you notice that there are so many people from all over Europe, so many medical specialists and others trying to find new cures. And I think that's the most encouraging thing that I took from the ELM. Secondly, what was very important, what was a very important message, I don't think, is that there are new medicines, luckily, which are developed, but that it is very important that to stay also on hydroxychloroquine, and that's a very and expected is also that it will be an important stay an important medicine for people with lupus, and that it's very important that we all take it regularly. So that were two of the, I think, the most important things that I noticed. One thing made me a little bit sad. That was in the sessions about minorities. That there was one colored lady who said that she was really shocked that she was almost the only colored lady at the ELM. And that made me, and also the other participants in the minority sessions a bit sad.
Yeah,
So there's something a lot of work for us also. Yes.
there is. Exactly. You're right. Yeah. Thank you so much, Elfriede. Yeah, and we have to not forget in all the new medications that are coming out that we also need to take the old medication still because it
Yes.
works.
Yeah.
Thank you. So next up is Lucy, and I want to mention before Lucy speaks that Lucy actually had the opening presentation at the very beginning of the European Lupus meeting. On behalf of all the patient representatives, Lucy gave her story. So, Lucy, will you give us a bit of feedback? And thank you so much for doing that presentation.
I apologise for the background noise if you can hear it. I just thought it was really nice that Lupus, all the Lupus Europe people there were so supportive and lovely. So thank you everybody. I thought the opening speech was amazing. I obviously didn't see much of it. I came back after the first day, which was good because my littlest had a huge group episode that night. But the opening speech was great and it was really positive, as has just been said, to see the kind of shift in the landscape in terms of new developments now compared to when I was diagnosed 17 years ago, and it was quite a bleak picture of kind of nothing really being licensed for lupus, nothing in the pipeline. So I feel like there's real hope that patients diagnosed in the future just have kind of a lot more treatment options available to them, and kind of current patients, kind of lots more treatments kind of seem to be in the pipeline, which is amazing. I thought it was fantastic to see how prominent the patient voice was all the way through the agenda of the meeting, and much more so in other conferences that I've attended that aren't lupus based, where there's a real kind of slim amount of patient voice kind of on show. And I thought it was amazing that even in the first session, the doctor referred to the difference in the doctor and patient view of a flare of lupus, because I think that's a huge issue in patients not feeling listened to and not being taken seriously. So to have that kind of really there from the outset was really, really good. And the agenda kind of did seem to show a real desire to align the patient and clinical view around kind of what matters and what's most important to the patient. So yeah, it just really felt that the patient voice does matter to rheumatologists and that they are trying to work collaboratively. So hopefully in future we'll have much more successful consultations where people do feel listened to and kind of much more beyond the lab results. That was it really. Sorry, Mike, I was only there for a day, so I didn't have as much to...
You got the most out of the day you were there. So
Yeah.
thank you so much, Lucy, and really wonderful presentation you did. So now we're going to hear from a representative from our youth group. So the hope for the future when it comes to patients. Samantha, would you mind giving us your feedback?
Hello. Not sure. Can you see me? Yeah, you can.
Yes.
Hi. Sorry for background noise. But yeah, some feedback. I think so. This was my first time attending a conference regards lupus, and I thought it was absolutely amazing. I've learned so much. It was great experience to meeting other doctors and speaking to them and going into the sessions and learning new things. It was interesting to hear about genetics and how it works, even though it was very high, uh, very scientific language. However, it was very interesting. Yeah, great debates about whether everyone, minority or majority, would need um, the biological drugs, or it could be treated by just without them. I really enjoyed the last one. Yeah, I think there was great discussions in regards the medication adherence, and it kind of got me to think that the doctors don't really speak to patients about this, about how important it is. So it really gives hope that doctors will start speaking to patients about how it impacts everyone's health, and what happens if you don't use that use the drugs. And I hopefully it moves forward in a more positive way, because it's a big problem in looking from the patient side and the doctor's side. Yeah, I think it's overall positive, very positive, hearing from doctors about new medications, new therapies coming into market. So there is definitely hope for us. And yeah, I'm very thankful for Lupus Europe letting me to attend this. Thank you.
Of course, and you did wonderful. So really glad we brought you there. So thank you. Next up is Delilah. So would you mind giving us your feedback? I think you also have a few slides you would like to share, or
Yes, that's right. Zoe, do you want to share or do you want me to share?
Yes, I'm going to share them now. Just give me
Very good.
10 seconds.
No worries.
Okay.
All right, thank you very much. It was wonderful to hear Lucy and Frida and Sabine and everyone about this session, because we all were there and we all experienced the same meeting from different perspectives, and it's really, really good to have these different views. So first I will say that, well, as you know, was in Bruges. As Janet already said, I think it was a very special and wonderful meeting. And as you can see here in these pictures, the city of Bruges is beautiful at night, and beautiful architecture as well, very inspiring. And well, one interesting fact that we got from there was that while most of us have water pipelines running under our cities, Bruges has beer pipelines running under the city. So that was very, very interesting to see and to learn about it. But it wasn't only about beer. Just in case, it was also about lupus, and mainly lupus. So this meeting was a great opportunity for learning and also for meeting everyone, our international working groups in person. And it was really, really good to see the PAM members, but also the physicians that we work with. And I would say, well, you can see there in the center, that's the venue where the meeting was. So also next slide, please, Zoe. Can you hear me? Yes, thank you very much. So after that, it was really good to attend the first session on genetics that we had. And as Alfreda said, and I think it was Lucy or Sabine who mentioned that it's very sad to see that some research is done in some groups and so others are not available. Some other groups have no research. So that's something that we learned also from this genetics session from Professor Weiss from London. He explained that there's no enough data, for example, in African ancestry. And even though this population is strongly affected by the disease, and it's something that we have to work on, we have to find a ways for having this population also involved in research. So this was really good, long session. Yes, I agree that it was full of medical terms and all of this, but somehow it was also, some of them were quite available for everyone else that was not involved in genetics. Then we had, in the meeting, we also had the poster session, and it was really, really busy, difficult to walk through. I don't know, for those who were, our PAM members that were attending, I saw you running and trying to go through, and it was the same for me. But it was really good. Also, we found there that there was new innovative approaches to managing lupus, not from pharma, not from drugs, but also from different approaches like training, exercise for fatigue. This was really good. And also we saw an app which was developed in Portugal. The training for fatigue I saw was in Germany. The app for learning about lupus and managing lupus was developed in Portugal. So this is new approaches for managing lupus. It is really positive. I also had the opportunity to present with Professor Marta, and the topic was quality of life, different perspective, physicians and patients. And I have to say, even though we disagree, obviously we see the disease from different points of view, we experience the disease from different points of view, there's the opportunity for finding agreement and improving our quality of life. So that's, in summary, what we said. And finally, I wouldn't miss the lupus nephritis sessions. There were plenty, but one key message, as we saw previously at EULAR, is that we need new tools. They are searching new tools for understanding, monitoring, and predicting lupus nephritis, which is very positive. And I'll say that's all from me because I spoke so much already. So thank you everyone for listening.
Thank you so much, Delilah. And you also made a really great presentation together with Marta Mowska.
Thank you so much on yours. I enjoyed it, but I said I wouldn't include anything about yours because I know that's you would add. Yes. Thanks.
Thank you so much. So, last up for the live presentation is Francesca, if you're with us. I know that Francesca was in her car earlier, and I don't know if she's arrived home. Otherwise, we'll wait until the end.
She's here, but I don't think she can hear us.
No, so we'll wait with Francesca. We have that to look forward to. So, as I said before, we have an hour of video for you guys to look at and hear all the interesting news from the European Lupus meeting. And Zoe, would you put on the video? Hi, so I'm here with
Yeah.
Great.
who
Thank
No,
has a
better.
very interesting poster upstairs, which I noticed was about fatigue. Could you tell us a bit more about the project?
Do you have the sound?
Yeah, sure, absolutely. So
We have the sound.
Yes, it's just a very poor quality. I think your bandwidth might be wrong.
It's better now.
Oh, I'm heading up.
It's a bit quiet. Can you maybe turn up the sound?
I don't have any sound here, which is weird. I need to change that.
Correlates with clinically, and we know that it doesn't typically correlate well with disease activity. Signal with a marker of abnormal iron metabolism. And so trying to bring that together with why patients may feel the symptom of fatigue, we realized that iron plays an important role in mitochondrial health, and mitochondria obviously produce energy. So the research that we presented was looking at the impact of iron deficiency on mitochondrial function in lupus, and is giving us ideas as to possible new ways of treating the symptom and a target for us to really try and exploit to see if we can alleviate this really troublesome symptom that patients frequently report that currently we find very difficult to answer.
Yeah, and of course, also frustrating for patients that we have fatigue, but we don't have activity in our disease. So how do we solve that?
Absolutely.
So, and if something as simple as iron might help, then great project. Really, I'm looking forward to seeing how it develops.
Thank you very much.
Hello, so my name is Ian Bruce. I'm Professor of Rheumatology at the University of Manchester. And I gave a talk today on JAK inhibitors and their potential use in lupus. So JAK inhibitors are a new family of targeted molecules with oral administration rather than given by intravenous infusions like biologics are. Because they block a signaling pathway called the JAK kinase pathway, what they do is they reduce certain proteins and molecules that are important in the pathogenesis of lupus. So things like interferons, interleukin-10, etc. And to date, there have been a number of clinical trials that I reviewed looking at JAK inhibitors in lupus. And there are currently 2 JAK inhibitors that are going forward into phase 3 trials. And they look very promising in the initial phase 2 trials. So now they're doing larger phase 3 trials to see what the full efficacy is. One of the things that we're particularly interested in is what pattern of disease that these will help with most. Will they be most beneficial for the skin, for the joints, or for the kidney, etc.? And so that remains to be proven.
Hello, I'm Ronald van Vollenhoven, and I had the opportunity to speak about a topic that concerns many clinicians, rheumatologists, but also concerns the patients, and it's how to choose wisely between the different treatment options. And specifically, if one has to choose among the biologicals, how to choose wisely? Well, I started by saying in my presentation that choosing wisely always means you have to have a lot of information available in your brain. So the brain makes all these important decisions. So you have to have all the data, all the information. That's why a congress like this is also very good. And then you can say that, well, right now, the recommendations for treating lupus include the use of the biologicals that are approved for lupus, which is belimumab and anifrolumab. And in the EULAR recommendations, it actually says that those can be considered fairly early on. Not, of course, for patients who respond well to antimalarials and some glucocorticoids, but if it doesn't work that way, then you could already consider the biologicals, in addition to also considering many of the more older conventional immunosuppressives, such as methotrexate, MMF, and azathioprine. Now, how to choose the biologicals? Well, you have to know what they can and cannot do. And I pointed out that there's a lot of literature on, for example, on belimumab, how it decreases disease activity, it prevents flares, seems to have a modest corticosteroid sparing effect. It also seems to be able to prevent some of the damage that can occur with lupus in the long run. And efrolimab also has shown that it can reduce disease activity, that it can prevent flares. And it seems to be particularly effective for skin manifestations. And it can also reduce the need for glucocorticoids. So these two drugs both have very good positives. But we also have to be fair about some of the limitations. And of course, the effects are not always 100% for each patient. So there's clearly variability in the strength of the effect. For some of the medications, we think that we can see a little bit of difference for the organ manifestations. So for example, belimumab has really been shown to have benefits for lupus nephritis when added to conventional therapy. That has not been shown for anifrolumab. Anifrolumab seemed to have very excellent efficacy for the skin manifestations, but perhaps a little bit less clearly so for the joints. So there are some subtle differences. And by weighing all these different aspects, the pluses and the minuses, I think in the end we will be able to choose more and more wisely for each individual patient.
So hi, I'm George Bersias from the University of Crete Medical School. Today I had the opportunity to present some data about the diagnosis and prognosis of males who are affected with SLE. So the key messages are that males can develop lupus, although lupus it is a female disease. There are males who can be afflicted, and actually there is sometimes a possibility that diagnosis can be missed because not many physicians think or have a high suspicion to detect lupus in men. But most important is the fact that often lupus in males presents with a more severe phenotype. So men with lupus often have lupus nephritis, often have serositis, and often will require pointed treatments at early stages. And because of that, and also the fact that they have many comorbidities, including for the cardiovascular domain, they often tend to develop damage more frequently than female patients with lupus. And there are also reports suggesting that their overall prognosis also is affected. Therefore, it is important that lupus is diagnosed early, timely treatment is initiated to control inflammation, to lower glucocorticoids, and to ensure the best possible prognosis.
Hi everyone, I am Andreas and I wanted to share my experience from the European Lupus Meeting that took place in Bruges, Belgium. It was my first time ever attending a scientific conference, and let me tell you, it was truly inspiring. The thing that struck me the most was the incredible level of passion and dedication from all the medical professionals I met there. They were doctors, researchers, and specialists, all coming together with one goal: to improve the lives of people with lupus. They were sharing the latest research, discussing new treatment options, and brainstorming ways to better manage this complex disease. It was clear that they are all deeply committed to making a real difference for lupus patients. I was also honored to co-chair a session focused on lupus and minorities. We discussed the issue of disparities in how lupus affects and is treated in different racial and gender groups. For example, research shows that lupus is more common and often more severe in women of color. They may also face challenges in getting timely diagnosis and accessing proper care. Our session aimed to raise awareness of these disparities and explore ways to ensure everyone with lupus receives the best possible treatment, regardless of their background. The European Lupus Meeting was an unforgettable experience, and it gave me a lot of hope for the future of lupus treatment. There is so much exciting research happening, and I truly believe that together we can make a significant impact on the lives of people living with this disease.
My name is Zeira Moura. I'm head of the internal medicine department in Pitié-Salpêtrière Hospital, and my unit is the French National Reference Center for SLE. Today I gave a talk on the strategies to minimize corticosteroid exposure in SLE. This is the major issue in SLE. And as I said, we need to try to decrease the use of steroids in SLE because prednisone is often used as a thermostat. I mean by this that when the patient is treated with prednisone, the patient himself or the doctor are increasing like a thermostat, are increasing the dose of prednisone. And at the end of the day, we have patients who are exposed to very high cumulative doses of corticosteroid and who have the significant morbidity and mortality induced by these high doses of corticosteroid. So we have now ways to not to start prednisone and not to turn on the thermostat. So there are ways not to use prednisone, especially for cutaneous manifestations. There are therapeutic alternatives to prednisone, like methotrexate, lenalidomide, or biologics now, and these drugs are very effective in cutaneous manifestations of SLE. It's quite the same for lupus arthritis. You can start by using pulses of methylprednisolone plus methotrexate without oral prednisone. So this is, I think this is the main issue in the future. Do not try to start prednisone for this manifestation. For other manifestations, it's much more difficult. If you have pericarditis or serositis, these organ involvement are very sensitive to prednisone, but you can often use immunosuppressants like methotrexate to rapidly taper the dose of steroids.
Well, hello, I'm Ana Malvar from Argentina. I'm a nephrologist and I work in a public hospital there. I've been working at the same hospital for the last 25 years. And one of the things I do there is to take care of the lupus nephritis patients. Today my talk was about biopsy and repeating biopsy. And this is because proteinuria, that is the way how when the kidney is affected, we can know if there's inflammation or not. Sometimes it is not enough because you may have an active lupus nephritis and you cannot have proteinuria, or on the other way, you can have proteinuria and your kidney may be not active. So in that cases, it's very, very useful for us so as to decide treatment to know what's going on really in the kidney. So that's why we have to repeat biopsies in some cases and know if the proteinuria is really because inflammation. Because you can have proteinuria and no inflammation, because when you have scars and the kidney is cured and those scars remain there, the same as happens in the skin when you have a wound, you can have proteinuria and it doesn't mean you have inflammation. So the repeat biopsy helps us to know if we have really inflammation.
In 2024, it was in Bruges, a very beautiful city, but we were there for the Congress, and a lot of physicians, researchers, and patients were present. We communicated on the same level. They may have great discussions and great sessions, and I was one of the ones that went through the genetic sessions. Very complicated, there's much more to learn, and there's a lot of things are going on, so there's a lot of work going on in lupus, and not a cure for lupus, but for a better treatment for lupus patients.
Okay. Hello, I'm Cristina Silva Santos. I'm a rheumatologist from Complexo Asistencial Universitario de León. The results of the survey are basically on the physician's experience in glucocorticoid treatment for SLE, and the results basically show that there are differences in the use of glucocorticoids based on physician experience. And we have shown that tapering protocols, withdrawing, and the use of pulses is different based on the physician's experience. Mostly that shorter experienced physicians on occasions use a higher doses of pulse therapy and sometimes for longer periods. We hope that these results can help us underscore the need to help with dissemination and implementation of evidence-based schemes, and hopefully, if we are lucky, we are hoping to do the same survey, although a bit adapted for patients, and perhaps compare the results of the two, so that maybe in the future we can try to work on some evidence-based schemes and perhaps know how we can use steroids while also minimizing the risk of organ damage.
So, hi everyone, I'm here with Cyril. We just made a really great presentation. So, Cyril, would you like to tell us a bit about yourself and what you just spoke about?
Thank you. So, my name is Sigrid Eppemo. I'm a PhD student at Oslo University Hospital in Norway. And I just presented this abstract from our large population-based SLE cohort that had included all SLE patients within the area of Southeast Norway. And what we find is that there's a clear accumulation of thromboembolic event around the time of SLE diagnosis. And this was particularly evident for APS patients. So the main message is that around the time of SLE diagnosis, clinicians and patients should be aware of this risk and do a proper risk stratification at the time of SLE diagnosis.
Right, thank you. So that really is important to know, that is, especially around the time of diagnosis,
yes, not
to be aware.
So not further along the way, but at the time, yes.
ELM 2024. What a nice convention. What a great meeting. We had the chance to be around with researchers and doctors specialized for lupus. Some things that I learned are, first, hydroxychloroquine. It's a medicine since 1950s, the safest one, and we can use it for many more years. Minority patients with lupus don't take part in clinical trial, and it's something that the researchers must work about it, and maybe we can help as patient advisory network. Patients with remission or low activity disease still experience poor quality of life. Good communication, very important. We must have a good communication with our doctor. And last, treat the mild lupus before become a severe lupus. Lupus Europe, thank you for the chance you gave me to take part in this great convention.
My name's Ian Bruce. I'm Professor of Rheumatology at the University of Manchester, and I'm leading an international project seeking to renew the damage index to assess long-term damage in patients with lupus. Currently, we think that the current damage index isn't quite sensitive enough to be used in clinical trials and clinical outcome studies. So therefore, we want to be able to measure more accurately changes in damage over time. And that's going to help patients because it means that we'll have a much better handle on which drugs work best to prevent long-term damage in lupus patients.
Hello, my name is Rita Torres. I am a rheumatologist in Portugal, and I was here in the Lupus Meeting 2024 presenting the results of sexual dysfunction in women with SLE. So what we did back in Portugal with a couple of different departments of rheumatology was to ask women with lupus to fill out a questionnaire online and completely anonymized about their sex life and their sexual function. And what we did have about the results was that 66% of our women with SLE had sexual dysfunction, and they all wanted to learn more and talk more about this with their physicians. We learned also that sexual dysfunction was associated with higher disease activity and a poorer mental health status. And this must be taken into account whenever we are evaluating a patient and giving them treatment and optimizing their management.
My name is Daniel, and I'm an internist, and I work in an autoimmune disease unit in clinical immunology. And I do research on lupus, both clinical and translational. And my talk here today was about the socioeconomical factors that affect the health outcomes of lupus patients. But I want the message to be a little bit more than that. I want the message to be that it is the whole context of the patient. So how the patient is, the kind of disease he has, but also where he lives and the people who surround him and, the country, etc. So all of that context needs to be assessed here, and it's very important.
Hello everyone, I'm Lena, and I'm here to tell you about the highlights I found during ELM. So during the opening ceremony, Dr. Eric Morant discussed the achievements made in the field of lupus over the past decade and what the future actually holds for us as patients. It was really interesting to learn that an evidence framework has been established for SLE and that the IFN hypothesis for SLE pathogenesis has been validated. So, as a patient, I'm really excited to hear about the possibilities that lie ahead. He actually mentioned of the potential to eliminate steroids, and that made me smile very much. And the idea of cellular therapies being a game changer also gave me hope. This is not for me, but this is especially important for newly diagnosed patients who will now have, or in the short future, may have more choices than I did 20 years ago. So this is really important, and I'm really glad to hear that.
Hi, I'm Christina Dusing. I'm a resident for rheumatology from the University Hospital in Düsseldorf, reporting from the Lupus Meeting 2024 in Bruges. My topic today was managing cardiovascular risk factors in SLE patients. And to sum up, the biggest findings is we have to be aware that our lupus patients have common risk factors that are known in the general population, such as hypertension, obesity, or diabetes, but they also bring disease-related risk factors, such as disease activity, current medication, and especially glucocorticoids. And as rheumatologists, we have to bring these risk factors together to find patients who need special examinations or extra treatment, because we know cardiovascular events are a major risk of death in our population, and they do increase mortality and impair quality of life in our patients. But it's a joint venture. We need other disciplines, but the rheumatologists, they're in charge.
Hi everyone, so my name's Maria. I'm one of the junior doctors working at Barts Health NHS Trust at the moment, and I've attended this lupus conference today, and I was delighted to be able to give a talk today, and it was to do with HPV vaccination, cervical screening in patients with lupus. And the study that me and my colleagues did was largely to do with female patients with lupus. And basically we did a survey to see sort of the uptake of the HPV vaccine and cervical screening in our patients with lupus. Because what a lot of people don't know is actually females with lupus, and just patients with lupus in general, are at higher risk of acquiring an HPV infection, and then the subsequent cervical dysplasia that can come from that. Dysplasia means abnormal cells that can then later become cancerous. So, you know, patients with lupus, because of dysfunction in their immune system that they already have, and also because a lot of them are on immunosuppressive medication, it means that their ability to clear the HPV virus, which is basically a virus that anyone who's sexually active can acquire. The whole point of the talk basically is to raise awareness about this. I'm not sure if patients with lupus know about this. I'm not even sure if a lot of clinicians know about it. And talk about it with their patients. All women who are aged 25 to 64 are eligible to have cervical screening. And a lot of women still don't go to have their cervical screening. And screening is so important.
Hello, I'm Ronald van Vollenhoven. I'm a rheumatologist from Amsterdam in the Netherlands, and I'm here at the European Lupus Congress. And I just had the opportunity to present data from the TULIP trials. These were trials that were done with anifrolumab, new biological that has been approved for some time now for the treatment of lupus. And in the TULIP extension trial, patients were treated for 4 years with either anifrolumab or with placebo. And what we were looking for in this analysis was how many patients achieved remission. We used the Doris definition of remission, and we were wondering how many achieve it because it's an important outcome. It means that you're doing really well. It's something we hope to achieve for as many patients as possible. Unfortunately, we cannot achieve it for so many patients yet, but we're getting better. Now, in this analysis, it turns out that in this patient population, about 30% of patients were able to achieve remission with anifrolumab, and with placebo, the comparator, it was a lot less. So we were pleased to see that anifrolumab can contribute towards this goal of achieving remission. We were also happy to see that it can be achieved in 30% of the patients. Of course, the glass is always half full and half empty, so there's also 70% of patients who did not achieve remission yet. We hope that with further advances, with learning more about the treatments that we have available today, using them better, and also with newer treatments, we will be able to achieve remission in more and more patients with lupus.
I was delighted to participate in the ELM in Bruges. I gained a lot of insights from this event. The voice of patients with lupus carries significant power and influence in various aspects of healthcare. Patients raised awareness about lupus by sharing their stories, experiences, and challenges. We can observe how patient voice helps educate the public, policymakers, and healthcare professionals about the impact of lupus on individuals and society. But by participating in PAN, focus groups, or advocacy organizations, patients can provide inputs of research that matters to all of us, such as identifying new treatments, improving quality of life, or addressing unmet needs in lupus care. As patients, we voice our treatment preferences, concerns about side effects, and overall quality of life priorities, leading to more personalized and patient-centered care. By sharing patients' journeys and supporting each other as patients, we created a strong community that empowers and shares valuable information. I'm very thankful for the opportunity to participate in this event. Of course, a special thanks to our lupus patients, speakers that caused a real storm of admiration.
Professor of Rheumatology at the University of Padua. Yesterday, I introduced a lecture on the targets of clinical treatment and the importance of follows this target in clinical practice. In other words, the treat-to-target strategy. And the treat-to-target strategy in SLE is a stepwise process, where the first step is to achieve remission, and when remission cannot be achieved, a low clinical disease activity. And the second step is to try to reduce and also to withdraw glucocorticoids, of course, if it is possible, And the third step is to reduce and also to stop also immunosuppressant, because immunosuppressant can contribute to the damage progression in SLEs. But so there are some difficulties in the application of the treat-to-target in clinical practice, because on the one hand, we have to reduce the disease activity and to achieve remission and low disease activity, but on the other hand, we have to reduce the standard of care. And so in this condition, it is difficult to succeed. And so we need some help. And what we think is that they use, especially the early use of biologics, in addition to the standard of care, can contribute to the success of the treat-to-target strategy in SLE.
Hello everyone, my name is Christopher Sjöman. I'm professor of rheumatology at Linköping, Sweden. And I'm here in Bruges to present one of our abstract contributions. And it's about lupus, low disease activity and organ damage in relation to patient-reported outcome measures in a Swedish cohort from Linköping. What we did in this study is that we used retrospective data from our single-center cohort in Östergötland, Linköping. And we included altogether 327 patients who were both incident and prevalent cases. And we have followed them over 11 years, both with clinical metrics and patient-reported outcomes, such as EQ5D and visual analog scale for pain, fatigue, and SLE, overall SLE health-related state. So, we then looked on how does this compare to both the development of organ damage and in relation to health damage. So our findings show that attaining ELM+ is extremely, is very strongly associated with improved patient-reported outcome measures. And this has been seen in different RCT, but it has actually never been proven in real-life observational studies. So what does this mean for patients? I think it's, again, underlying the importance of reaching the goal that we set up. We need to get patients into remission, and if remission is not possible, we should aim for low disease activity. And this actually has impact. Our study shows that this has impact also on the patient's health experience. And the conclusion we have based on our data is that patient experience should be an integral part of the evaluation.
I'm Martin Aringer, and what we've been looking at is now it's almost 5 years. In September, it will be 5 years that the EULAR-ACR classification criteria for lupus were published. And mainly we were looking how they were doing from the outside view. So obviously within the study, the results were excellent, but now there's a total of 28 external validation studies. And overall, it is true that essentially all patients have ever had ANA. And with regard to sensitivity, we are slightly lower in the outside view, but that is also because early disease is more difficult. And with regard to specificity, so not classifying somebody with lupus who has, for example, rheumatoid arthritis or so, we are exactly in the range that was predicted. So overall, the results proved to be fine, and the whole system works. What is sometimes difficult is the attribution rule. So items count only for lupus if there's no more likely other explanation. And if you don't do that properly, specificity obviously drops because you will include RA and the like. And that is something we saw. But that's a solvable problem. And It also looks like a lot of clinical trials, phase 3 clinical trials in lupus now use the new criteria, which is exactly what we hoped for. So after 5 years, it pretty much looks good, and there's no negative surprises at least.
It seems really encouraging that the 14th European Lupus Meeting is so successful. The participation of doctors from various parts of the world is important for the exchange of knowledge and advisement for research and treatment. The doctors were positive and willing to answer patients' questions after each presentation. The active patients' involvement is crucial for better understanding the disease and achieving optimal outcomes in their treatment. Of course, the participation of patients in such events represent a significant steps towards the improvement of patient-centered care. I really impressed with the fishbowl discussions because are an excellent method for exchanging opinions. They are allowing participants so freely to express their views and emotions and listen to others, of course. It is great to hear that everyone has the opportunity to participate in these discussions. And as a patient, I express my opinion, especially regarding my experience with fatigue, which is so also important to the doctors to understand exactly how patients experience fatigue, so as to adjust new therapeutic approaches and advices for improving our quality of lives and for sure symptoms management. Lastly, I want to say again that I really impressed with the openness of doctors to listen and to answer patients' questions, which is fundamental for a more collaborative and effective therapeutic approach.
Okay. Hi everyone, my name is Maria Legato. I'm professor of rheumatology at the University of Turin, and today I would like to share with you the results of an ongoing study that we are carrying out with colleagues from other centers of nephrology and rheumatology in Italy. And we deal with, of course, SLE and lupus nephritis, which is the core of our research. And in this study, we really wanted to identify the minimum duration of renal remission and extra-renal remission that can be protective against the loss of function of the kidneys. So that is important for preserving a favorable long-term prognosis. So we performed a study on over 300 patients who had biopsy-proven lupus nephritis, and by checking the evolution throughout the year, so over 15 years of follow-up, we could see that most of them, up to 80%, were able to achieve a sustained clinical remission, which is good. And among those, we noticed that most of them were protected against the loss of renal function and in general by the accrual of organ damage. The protection was associated with the duration of follow-up time that the patients could spend into remission. So that means that the longer the time spent into remission, the better the protection against the damage and the loss of renal function. By analyzing the duration of remission in detail, we saw that at least 3 years of clinical remission, that means renal and extrarenal clinical remission, is associated with a significant protection against renal damage and overall organ damage in lupus. So the clinical message is that lupus nephritis is indeed still a severe manifestation. It needs an adequate and timely treatment, and this treatment has to be profound in the beginning and has to last a consistent time span in order to guarantee at least 3 years of remission before we attempt to taper and withdraw the immunosuppression.
Hello, I'm Elisabeth Svenungsson from the Karolinska University Hospital and Institute in Stockholm, and I talk today about subdividing lupus patients into subgroups based on autoantibody profiles. And what I did was that I went through the literature for over 20 years and showed several, quite many studies actually, that have used the antibody profile to subdivide patients into different subsets. We also showed that the antibody profiles can predict outcomes prospectively, but this work is ongoing and it was only some preliminary data that I could show. So then what are the characteristics of these antibody subsets? I think there is one antiphospholipid positive group. There is one SM-RMP, sometimes with nucleosome, sometimes with dsDNA positive group. There is one more SSA, SSB roll-up positive group. And then there is another group where you see very few antibodies.
What I say is that hydroxychloroquine is a very good treatment with many beneficial effects for the patients regarding damage, efficacy and flares, and even survival. So it's a treatment that should be taken. And I discussed adherence to the treatment because the issue is that patients don't always take the treatment. And in such case, there is a risk of flares and damage and even death.
So, and what's about the protective effect of a hydrochloroquine during pregnancy?
Yes, during pregnancy, it protects against flare, essentially. This is very well proven. The efficacy and adverse pregnancy outcomes, I mean preeclampsia and so on, is not so proved. Probably yes, but we don't have many proofs of that. But we are sure it prevents flares, which is important because when the mother has flares, it's not good for the fetuses.
Hello, this is Kikka from Helsinki. My 3 takeaways from the Lupus European meeting in Bruges in March 2024 are these. First is Eric Moran, an Australian professor of rheumatology. He gave an opening speech at the conference, and he was talking about the major achievements in the past decade. And I just wrote down what he said, that almost 29,000 research papers were published between 2014 and 2024, but only 2 drugs. He gave us major achievements, the treat to target and EULAR recommendations for the treatment of lupus, and the combination therapies treating lupus using a biologic and an old some other drug together to avoid cortisone. That was the main thing that he was saying, that we've been able to push down or bring down using cortisone in the treatment of lupus, because that has the worst side effects in the long run. So this looks promising. The second one I'm talking about is from session 14 about lupus in minorities, and especially Antoine Effran's speech from France about lupus and ethnicity. And I was surprised to find out that there is racism found in healthcare. The patient have reported this, and it's also in the healthcare system. Unequal access to healthcare, that is the main cause. Delayed or decreased access to specialty care and diagnosis, that sounds bad. And also the clinical trials the minorities are very underrepresented in them. Less than 15% of the patients in clinical trials are from ethnic minorities. So there is a thing to improve. And my final one is, of course, Nathalie Coste-Duar and her speech about in the session 7 that I co-chaired with Professor Marta Mosca from Pisa University. The session was about best approaches to manage risks. And Coste-Duar talked about hydroxychloroquine, of course. And I didn't take any notes. I was co-chairing. I should have, but I was just listening. And what she was saying is that please continue with your hydroxychloroquine. It's the best to manage risks of all sorts, atherosclerosis and all damage, and to prevent lupus from activating. So if you can, please keep on taking hydroxychloroquine as you have so far.
I'm Marina Botto, and I'm a professor of rheumatology at Imperial College in London, and I've been always interested in lupus, and I'm a clinician looking after patients with lupus. So patients with lupus, we know they have a high level of this molecule that we call type 1 interferon, which is in terminology called a cytokine. And cells in the patients respond to this cytokine. Now, cells like us, as a human, needs energy. And that's what we call a metabolism. So each cell is like a human body that needs food, which is essentially the mechanism by which the cells survive. So in my presentation, what we've shown is that this cytokine, this interferon, changes the type of food, the type of energy that the cells need to survive. And having this high expression of type 1 interferon make the cells to become less capable of responding to another stimuli. So if there is an infection, the cells need to respond, but because of the type 1 interferon, their energy, their capacity to produce energy is altered, and therefore the cells may die more easily.
Thank you very much. We appreciate this. Thank you.
It's a pleasure.
Hello, I am Angela Tincani. Today we will speak of the pregnancy in lupus patient. This is something that we discussed for many years, but still there are some problems that are unsolved, or at least in my view they are unclear, and some of them are related to the counseling, because nowadays, you, lupus patient, know a lot about the relation between pregnancy and disease, about the children, about the reproductive issues in general. So what probably the doctor has to do is just to personalize the counseling to the patient that he has in front, and in this respect has to think to all the possible risk factors that this patient is carrying in case of pregnancy. And among these there are some that are not clear because the opinion in this area can be different. One of them is what does it mean high risk antiphospholipid profile. Somebody think that only high titer antibody are dangerous. Some other think that especially in the field of pregnancy, also low titer are important. This is something because it change the way of treat the patients. And so there are other issues like the use of aspirin, for example, because for some doctors has to be used always in lupus patient, and for others only in specific patients. So this also is something that can change the outcome of the pregnancy in some case. So what is important in my view is to keep in mind that nothing is written on the stone, and that we have always to compare our opinion and be ready to change in a way or in another for the good and the health of our patient.
Hello, my name is Lynette Borte, and I am a member of the Lupus Europe youth group, and I'm a leader in this group. So the 14th European Lupus Meeting 2024 in Bruges was my first ELM conference. As a sufferer of lupus, SLE, of 23 years, I got a lot from this congress on the various lectures and topics of lupus. I felt well educated and informed on the different lectures that I attended. I planned the sessions I wanted to go. I attended lectures on the following: biologic drugs, various lectures on pregnancy, lupus drugs and adherence, interacted in poster sessions. I went to the benefits of having a nurse, lectures, working towards SLE and damage index, long-term follow-up on the University College London cohort, ethnicity in lupus, males with lupus, economically and socially less advantaged patients with lupus, HP vaccinations and cervical screening in lupus patients, managing fatigue, lupus nephritis, quality of life, and lupus fishbowl sessions on pregnancy. As a patient with lived experience of lupus, I felt that I was well informed during this congress and learnt more about this chronic condition. The managing the fatigue session was very interactive in consideration of the patient's perspective. It also used layman's terms which was easy to understand. I really enjoyed the fishbowl sessions as these were interactive and were patient friendly. I liked the fact it was conversational. I was well informed on the importance of getting vaccinated on HPV and getting cervical screening checks. A lot of the speakers were approachable and were happy to be interviewed, which gave you a better insight of their talk. I enjoyed interacting with the speakers and the experts of this condition. In conclusion, I gained a lot more knowledge of the different aspects of lupus, especially the ones that do not affect me personally, for example, lupus nephritis. This has enabled me to be better informed, which I can use these skills to support the Lupus Europe youth group.
Hi, I'm Jane Salmon from the United States, from the Hospital of Specialty Surgery. I've been studying lupus for 40 years. And I can finally tell you some good information related to pregnancy outcomes. First, most importantly, don't get pregnant when your disease is active. Low activity, low doses of steroids, inactive nephritis, no proteinuria, that's the time to become pregnant. If you have antiphospholipid antibodies, talk to your physician you likely need aspirin. Actually, any lupus patient should probably take aspirin during pregnancy. If you've had thromboses, that is blood clots, or pregnancy complications related to intravascular antibodies, it's probably important to take not only aspirin, but low-dose heparin therapy. Now, all that I've told you thus far is standard of care. What I'm telling you next is a clinical trial. So there is a new medication that we've tested in a trial that seems to be very effective in preventing preeclampsia in patients with antiphospholipid syndrome. Preeclampsia is toxemia of pregnancy. It's not yet in the label. It's not approved. The study isn't complete. So I'm not recommending it, but I can give you optimism that we will publish this work soon and there will be opportunities. So thank you and good luck.
Hello, here are my 3 key takeaways from European Lupus Meeting 24. And number 1, the lupus patients and Lupus Europe are on the map. It's very clear. Most of the sessions refer to patients, and Lupus Europe was regularly acknowledged. Our data from Living with Lupus in 2020 is really making its way to doctors and is now used to present the reality of lupus for lupus patients. Doctors recognized the need for patient input, and we had several co-organized and co-chaired sessions, which is great to see that collaboration between Lupus Europe and the doctors. Number 2, we were also present through our RAID strategies. In 22, we had interviews and we had tweets. In 23 at EULAR, we had the Lupus 100 leaflets that got us noticed by everyone. Here in 24, we had again the interviews, the tweets, the Facebook presence, but also the questioning of the doctors that have done research and had posters where we asked what was the role of patients, and that really triggered a number of questions on how we engage with the doctors. So that's great. And number 3, from a medical point of view, I was really struck by the presence of hydroxychloroquine as a key item that regularly came back, and I think that was very interesting for me to see next to many other interesting scientific reports.
Yes, thank you everyone for giving your feedback. I apologize, we had to shorten some of the videos because we simply ran out of time, but all the videos will be available on YouTube afterwards. So we still have missing a presentation. So Francesca.
Hello, I'm Francesca. I'm part of the Patient Advisory Network and since little time also part of the board meeting of Lupus Europe. I think that everything has been already said during this meeting. So for sure, it's always very nice to see all the new development in drugs and so on. But just one takeaway that I would like to share with you, it's about the non-pharmacological treatment. That's because I have presented a poster on this topic, and it was really nice that this topic was disseminated in a lot of different presentations during all the Congress. So each time, that's not for me, it's not the first time I participate in the Congress, but what I notice is that each time the patient is more in the center, not only as to test him or to give drugs to him, but as a whole person. So it's more and more seen as a person and not only a patient. So that's my takeaways. Thank you very much.
Thank you, Francesca. Yes, I completely agree. And that's also some of the feedback I want to give from my version of ELM is really noticing how important patients are becoming and how patient-focused all the sessions are. So it also shows the value of taking part in any research, any questionnaires that are sent out, because you actually give feedback to doctors about how it is to be a lupus patient, and they are really interested in knowing that. So I had a lot of meetings. I didn't go to as many sessions, but I was helped by all these lovely people who were they were my army, going out to all the different sessions and listening in and having interviews with people. So thank you so much, everyone. What I did have was meetings with researchers and industry partners, and no matter who I spoke to, I got a positive feedback about patient involvement and engagement. So people were very, very excited about all the patients, and they really loved hearing the patient point of view. We also had a Lupus Europe joint session with co-presentations where patients and physicians spoke together. Delilah already mentioned it in a session called What Really Matters for Patients. So we had a session on fatigue, on quality of life, and shared decision making. We had patients as co-chairs for sessions. We had patients in fishbowls. We had patients doing interviews, as you've just seen. So a very positive note. The next organizer of the European Lupus Meeting, Luis Suzainez, has already contacted us. He wants to collaborate with Lupus Europe on the next European Lupus Meeting in 2026, which is going to take place in March in Portugal. So amazing work, everyone. Thank you to all the physicians who so generously shared their content of their sessions, and especially to all the patient participants. As you heard from Lynette, they were in so many different sessions. So what you saw and what you heard is only a small part of what they actually did. Thank you so much, everyone. So lastly, the last thing I want to leave you with is a reminder that we now have the Swiss Knife Survey, which is the follow-up from the Living with Lupus survey. It's live in a lot of different languages. If it isn't available in your language, contact us and we can work together. Please spread this questionnaire. Make sure that we have as many answers as possible, because as Alan said, the previous survey we made, all the data from that is now being used in doctors' presentations, and we want the same to be applicable for the Swiss Knife survey. So answer the questions, and thank you so much to everyone who listened in and who is interested in what we learned at the European Lupus Meeting 2024.